This is the induction program for PRUH. The topic now is delirium. Delirium is a serious disturbance in mental abilities that result in acute confusion and reduced awareness of the environment. The onset is usually rapid, that is within hours or a few days. Delirium can often be traced to one or more contributing factors, such as severe acute or chronic illness, medications like opioid analgesics, benzodiazepines, mood stabilizers, antihistamines, steroids, anti-Parkinson's drugs, anti-epileptics, alcohol or drug intoxication, or their withdrawal. Infections like any fever or acute infection in children, or UTI, pneumonia, or flu in elderly. Medical conditions like stroke and heart attack, metabolic imbalances like hyponatremia, hypocalcemia, hypoxia, hepatic or uremic encephalopathy, exposure to toxins like carbon monoxide, cyanide or other poisons, sleep deprivation, pain, surgery or other medical procedures can lead to delirium, and it is possible that more than one factors are playing together to cause delirium, like a patient with the exacerbation of COPD, hypoxia, and steroid may work together to give rise to delirium. The symptoms of delirium are reduced awareness of environment, cognitive impairment, behavior changes, and emotional disturbances. In next few slides, we'll discuss these symptoms. When the patient have reduced awareness of the environment, it may result in an inability to stay focused on a topic, or the patient may switch topics, or they can get stuck to an idea rather than responding to questions or conversations. Patients can easily be distracted by unimportant things, and sometimes they are withdrawn with little or no activity and do not respond to the environment. With cognitive impairment, patient may exhibit poor memory, particularly for recent events. They can be disorientated in time, place, and person. They would have difficulty in speaking or recalling words. The speech can be rambling or nonsense. They would have trouble in understanding what other person is talking about, and they would have difficulty in reading and writing. In delirium, there can be behavior changes as well. Sometimes there are hallucinations. Some patients can become restless, agitated, or have combative behavior. Patient can start calling out names, or they keep on repeating the same sentence over and over again. Some of them become quiet and withdrawn, especially in elderly. They can be slowed movement and they seem lethargic. They can be disturbed sleep habits like reversal of night-day sleep-wake cycle. There are emotional disturbances in delirium that may appear as anxiety, fear, or patient may look paranoid. There might be depression, patient might be irritable or angry, or there may be a sense of feeling elated. There can be apathy as well. So there are rapid and unpredictable mood shifts and personality changes. There are two types of delirium. One is hyperactive, another one is hypoactive delirium. Hyperactive is the one that is most easily recognizable. This includes restlessness, agitation, rapid mood changes, and hallucinations, and patient may also refuse to cooperate with care. In hypoactive delirium, there is reduced motor activity, abnormal drowsiness, or patient may seem to be in a daze. There can be a mixed delirium where the patient switches back and forth from hyperactive to hypoactive, and then may go back into hyperactive again. In summary, patients in delirium become more confused than normal. There are changes in alertness. They have a lack of concentration, or they become easily distracted. They become disorientated. There is rambling speech. They show changes in behavior, and they also have disturbed pattern of sleeping and waking cycle. They are more prone to rapid swings in emotion and experience hallucinations. They have abnormal or paranoid beliefs. So how can we differentiate delirium from dementia? Symptoms of dementia develop over time. It may take weeks or months, and deterioration is seen in years. The symptoms consist mainly of memory loss, difficulty in performing familiar tasks, so much so that in advanced cases, patient may forget how to put on clothes. There is problem with language. They are disorientated to time and place, and in advanced cases, they can even forget their loved ones as well. There's poor decreased judgment that can be seen in taking risky behavior in financial matters. There's problem with keeping track of things, and patient keeps on misplacing things like car keys or important papers. There are changes in mood or behavior so that patient can become agitated and argumentative. There are changes in personality like once affectionate and caring person can become aloof. So what are the risk factors for delirium? The risk of delirium is highest in people with dementia and people who are dehydrated or have a poor appetite. Any infection can lead to delirium, particularly UTI, constipation and urinary retention. Older people without any other cause may develop delirium. People who had surgery, particularly hip surgery, older people taking multiple medications, patients with sight and hearing difficulties, patients who are nearing the end of their life. And it should be noted that pain itself can cause delirium. Patients in an unfamiliar, distressing environment, for example in ICU, can develop delirium. And what are the risk factors for dementia? Age is the highest risk factor for development of dementia. Risk doubles every 5 years over the age of 65. However, 1 in 20 patients develop it under the age of 65. Being a woman increases the risk. South Asian population is especially at risk, particularly for vascular dementia. Apoprotein E, a certain type of apoprotein E, that is epsilon E4, is seen to be associated with Alzheimer's. Cardiovascular risk factors like obesity, lack of exercise, and smoking can also increase the risk. Patients with Parkinson's, HIV, multiple sclerosis, and Down syndrome are more at risk. Patients with alcohol excess can develop dementia. How to help these patients? Keep calm and reassure the person. Use short, simple sentences when talking. Observe the person to see if they are in any pain, and if they look in pain, they give analgesia. Make sure there's nothing obscuring their senses and have their glasses and hearing aid to hand if they use them. Use familiar photos and objects to distract the person and provide familiarity. Help ground the person by making sure they know the time and date. Help the person to find the toilet if needed. Avoid too much stimulation and having too many people around if possible. Keep a low light on at night. Avoid disagreeing with the person too much. Offer them drinks to maintain hydration. Now, how to deal with delirium? Number 1, look carefully for delirium and the risk factors like pain, infection, constipation, dehydration, medications, and environment. Correct these risk factors and then use 480 to help the diagnosis. Sleep deprivation and alcohol can worsen the delirium. If the patient uses glasses and hearing aids, put them on. Number 2, harness the power of the family. Listen to family, friends, and carers who can tell you if the patient is confused or if he is at his baseline. Find and stop the culprit medications. If you have to use any medication for agitation, then use the lowest doses of haloperidol or olanzapine. Use benzodiazepines only if antipsychotics are contraindicated. Number 4, orientate your patient with clocks and calendars nearby. Thank you very much.